Welcome to The Code Tray, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website. Today, we have Sarah Markovich, who is a PGY2 emergency medicine resident at Penn Presbyterian Medical Center. She'll be presenting the journal club on Succinylcholine versus Rocuronium for pediatric rapid sequence intubation in the emergency department. Thank you.
RSI is going to be the rapid administration of a sedative and a paralytic agent as opposed to conventional intubation, which utilizes deep sedation with either a delayed or no paralytic administration. And this happens in upwards of 80% of pediatric ED intubations. This will also likely result in a higher incidence of first-pass success in our PEDS patients. Albeit pediatric intubations are generally more difficult than our adult intubations, even despite the use of these RSI techniques, we still see a failed intubation attempt at a much higher rate than we do in our adult patients. This is likely due to the infrequency of the procedure in this population, key anatomic differences such as a smaller, shorter, narrower trachea, prominent occiput, large tongue, tonsils, and adenoids. And there are also few pediatric studies comparing paralytic agents against each other for this population, so that will then be the focus of today's article. When I think of the perfect RSI agent, I think of a few key things. First is having a fast onset, having a limited duration, and having little to no adverse effects. Using this recipe, let's take a peek at our paralytic agents that are very commonly used in RSI, both of which will be discussed in the article later on. Succinylcholine is our first one. It's a depolarizing neuromuscular blocking agent having a very rapid onset with a brief duration. It does have some key disadvantages in terms of adverse effects and contraindications, such as hyperkalemia, malignant hyperthermia, and then known adverse effects, muscle fasciculations based on its mechanism, and then some bradycardia. Another agent would be Rocuronium, which is our non-depolarizing neuromuscular blocking agent, with a slightly longer onset of action and then a much longer duration, but it doesn't have any of those adverse effects that we discuss with succinylcholine. Putting our literature that we'll be discussing today into context with some existing literature that exists previously, we have the ED awareness study from 1977, single-center prospective observational study in mechanically ventilated adult ED patients who on extubation were assessed for awareness with paralysis utilizing the Bryce questionnaire, which was independently reviewed by 3 adjudicators. And the primary outcome was the prevalence of this awareness with paralysis. This was found to occur in a significant minority of ED patients who receive mechanical ventilation, and it was also associated with exposure to Rocuronium, which, as we just discussed, was one of our longer duration paralytics, meaning there was a likelihood of patients having a period of time where the paralytic was active without probable adequate sedation. Our next study is from Tran and colleagues in 2015, who conducted a Cochrane review of randomized controlled clinical trials in both peds and adults with reported scores of intubating conditions as our primary outcome. The comparison was Rocuronium of 0.6 mg per kg or greater to succinylcholine at 1 mg per kg or greater. Succinylcholine was found to be superior for producing both excellent and clinically acceptable intubating conditions. There were no reported severe adverse effects, but due to the high incidence of detection bias and significant heterogeneity, the authors said that this would provide moderate quality evidence overall. Lastly, Kumar and colleagues in 2023 conducted a single-center, double-blind, randomized comparative study of 200 pediatric patients between the ages of 1 to 14 years old, presenting for an elective surgery but were otherwise healthy. The primary aim was to assess intubating conditions, again using the same scale, and then the secondary aim was measuring hemodynamic responses to the laryngoscopy and intubation. Intubating conditions were found to be better in the Rocuronium group, but it should be noted that both groups had largely good or excellent rated conditions overall. The only adverse effects were the fasciculations seen in the succinylcholine group, and hemodynamics were comparable. So what the study we'll be discussing today would add is specifically more data in our pediatric patients, especially in the emergency department, which would increase applicability into a setting where a lot of us practice. And seeing that it is likely that both are clinically acceptable, this study also adds some mortality data in this population. So moving forward with this study, this is a retrospective propensity-matched analysis utilizing the TriNetX database, which housed data from 69 healthcare organizations across the United States. Authors collected data on the use of succinylcholine or rocuronium during intubation in the emergency department, and then information on subsequent outcomes of interest, which we will talk about soon. Selections were made using ICD-10 codes and NLM keywords, and this was done over the period of approximately 20 years. For our inclusion criteria, patients must have been less than 18 years old at the time, intubated in the emergency department, received either etomidate or ketamine for the induction agent, and then were separated into cohorts based on the paralytic used. So cohort 1 being succinylcholine, cohort 2 being rocuronium. Exclusion criteria included the PTSD diagnosis prior to admission and any use of the alternative paralytic agent. I also want to mention the study did use this cohort terminology, though for simplicity today, I'll refer to the cohorts by the name of the paralytic agent used. Those outcomes of interest we mentioned include death, which was assessed through database demographics, including the EMR data in conjunction with national death registries. Post-traumatic stress disorder, identified through ICD-10 code, measured at discharge from the hospital, and this was done for patients 8 to 17 years old based on existing literature that outlined appropriate ages to assess PTSD, and then any noted instances of malignant hyperthermia. All analyses and propensity matching were conducted within the TriNetX software, and propensity matching was based on predetermined characteristics seen off to the right of the screen using the greedy nearest neighbor algorithm. A priori statistical significance was established with a two-tailed alpha set at less than 0.05, and linear and logistic regressions were utilized as appropriate for the data. Subgroup analyses compared succinylcholine and rocuronium in the induction agent cohorts, and each of those induction agent cohorts again excluded patients who received the opposite induction agent. Post hoc analyses were performed to assess relationships between mortality, indication, and the paralytic agent used. Moving forward into our results, the succinylcholine cohort had 712 patients initially, and rocuronium had 1,383 patients. And there were some differences in age, ethnicity, and comorbidities, which were all no longer significant after propensity matching. We also had 706 matched pairs, leaving 706 patients in each cohort after propensity matching. Looking at those big three outcomes in our main analysis, we can see that there was a significantly higher mortality in the rocuronium group, both before and after propensity matching. And though there was a higher PTSD occurrence in the rocuronium group, this was not found to be statistically significant either before or after matching. Additionally, for malignant hyperthermia, there was only one possible, albeit unlikely, occurrence prior to propensity matching, so this outcome could not be further adequately assessed. Looking at subgroups by the induction agent, we can see that succinylcholine and etomidate had the lowest mortality rate at 7%, and rocuronium and ketamine had the highest mortality rate at just over double at 16.4%. When comparing these two values, there was a significant difference seen, and the other two cohorts, the succinylcholine and ketamine, rocuronium and etomidate, were very similar as well, closer to our succinylcholine and etomidate cohort. In terms of our indication post hoc analyses, we can see for both acute trauma and asthma, which are linked with higher mortality after ED-RSI, that we had an approximately even distribution of patients between the succinylcholine and rocuronium cohorts for each indication. This suggests that the succinylcholine and rocuronium cohorts were relatively similar in terms of indications for intubation. The authors concluded that this study demonstrates a potential association between succinylcholine and favorable RSI outcomes, but further prospective studies are needed to determine causality. The subgroup analysis also suggests that succinylcholine and etomidate may be a preferred combination, and there are no significant differences in the rate of PTSD when comparing groups. For the rest of the discussion, I identified some key strengths and limitations that I wanted to walk through with you. This was a large database and a large population, which would minimize the impact of any one institutional policy. I also liked that they did the subgroup analysis by an induction agent, which highlights potential impacts of induction agent on outcomes and creates future avenues for research. And the propensity matching did minimize confounders in the baseline population. There were also some key limitations, a lot of which around the retrospective nature of the study. There were inherent biases and confounding that could potentially not be fully accounted for despite the propensity matching. I also wanted to mention that the procedural information of interest was a bit lacking. We didn't have any information on exact doses used, nor rationale for why one agent was chosen over another. We also didn't have data on whether it was a first pass success versus a failure, or the number of attempts needed, or the time to successful intubation. Additionally, we were unable to account for clinician practices or institutional policies, any kind of skill levels attributed to the clinicians. And heavy use of ICD-10 codes, while it makes sense for a retrospective study of this size, also relies on appropriate, complete, and timely documentation, which may introduce inaccuracies or missing data. I would also like to take a moment to point out that the PTSD diagnosis at the time of discharge is also very likely cherry-picking select patients with extreme experiences, as it's possible that many patients may not be diagnosed until well after discharge. In terms of the subgroup analyses, they didn't include any data on the statistical comparisons of the other combinations. They only picked the best and the worst, with them being almost double the other. I would expect this to be significant, but I'm interested in what the other ones turned out to be. Also, we have no comment on stratification by time. And while it is likely that both groups were analyzed over the full 20-year time frame equally, trends in use cannot be excluded. For example, maybe Rocuronium was more prevalent in early years, and there's some bias on clinician skill progression, or maybe there are spikes, temporal spikes according to maybe July and August with inexperienced clinicians. And those are just things we can't account for based on the data presented in this study. Additionally, the time of mortality is unknown. It could be immediately after, several days after. The authors chose to analyze up to 60 days based on the thought that it was important to include these later deaths in children who may have severe anoxic injuries and would die later on. But not having this time to mortality could potentially introduce a host of confounding variables that were not addressed using the propensity matching. In terms of key takeaways from this article, based on the data presented here, succinylcholine does have a potential mortality benefit over rocuronium in this study, but I do think that this should be confirmed by prospective data. I also want to take the time to bring back again the rocuronium and ketamine subgroup, which is being so vastly different than the other subgroups. It's kind of an outlier. Seeing that both of the succinylcholine subgroups were similar to the rocuronium and etomidate, it's likely that succinylcholine won't give a worse mortality though, which does still support my use in pediatric patients, that if I use succinylcholine, at the very least, I'm not increasing their mortality risk. And I think it's important to recognize the strength of the evidence behind this recommendation, to read the room, individualize decisions, assess patients thoroughly for contraindications, and also recognize a part of provider comfort. First pass success is best for the patient, so let's support them in getting there. This particular study does not present strong enough data for me to make wide, sweeping blanket statements on use. I tend to gravitate towards succinylcholine in my adult patients, and without contraindications based on this and the historical literature that I'm aware of, I will likely not be making any changes to that practice for pediatrics. So that was my review of the article. Thank you all for being here today, and I am more than happy to take any questions you have at this time.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. and the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.